I'm Joe DeMattos. I'm the President and CEO of the Health Facilities Association of Maryland. We are the largest, oldest nationally affiliated association of skilled nursing and post-acute care providers in Maryland. Maryland has a very unique opportunity now going forward. So while Hawaii in 1974 established universal coverage, a couple of years later there were a number of states that went to CMS, the Centers for Medicare and Medicaid, and they made a proposal. And here's what the proposal that they made back in the 70s, these 4 states. They said, you know, Medicare, if you allow us to set our own prices and to use our own system of rating acuity, we will have Medicare in our state grow slower than the national average. And you'll just give us a pot of money and we'll do that. So Maryland made that bet, Maryland's hospitals made that bet with the federal government 30 years ago. And that bet has turned out to be a very, very good one for all involved, for the federal government, for the state of Maryland in terms of the economy, and in terms of the hospitals. Because of what it meant in Maryland over the last 30 years is that our hospitals were able to provide quality care at a lower growth rate than the rest of the country. The way Maryland did it, unique to the country, is we created a cost review commission. And so in Maryland, the price of procedures and which hospitals can offer which specific procedures have been regulated for about 30 years. The result of that is that you haven't seen in Maryland over the last 30 years the cost shifting that you've seen in other states for uncompensated care. The price is the price across all care settings, and so you have a much lower percentage of uncompensated care in the hospitals historically in Maryland than you have the rest of the country. But there was a flaw in the system going forward, and the flaw in the system was that it didn't put enough emphasis on utilization and on outcomes. So a couple of years ago, Secretary John Colmers and Secretary Josh Sharfstein, working with their economists, realized that in a couple of years we were no longer going to be able to meet the threshold test of having costs less than the national average. And so they got into a national dialogue with CMS, and they created a new waiver, which we've now had in place for a year. So Maryland now has a new hospital waiver that not only focuses on sort of being the spear of cutting-edge healthcare delivery for the next 30 years, but very specifically links spending, utilization, and outcomes. And so we could, going forward, be the model of the rest of the country relative to that, because what it'll mean is that hospitals will have to partner with other providers, such as skilled nursing and rehab centers, and skilled nursing and rehab centers and home health care companies will have to partner with hospitals to make sure that care is more integrated and produces greater clinical outcomes. It scares me that we live in a state with the best hospitals in the country, perhaps in the world, but we still have tremendous healthcare disparity because of the lack of access to care historically, and because of the lack of integrated care historically. That concerns me. It concerns me that when the federal government passed the stimulus package and they underwrote electronic medical records for hospitals and physician practices, that they didn't underwrite the cost of those electronic medical records for skilled nursing and rehab centers. So what that means is that most hospitals and most physicians across Maryland and the country have robust, meaningful use electronic medical records. But what it means here in Maryland is about only half of the skilled nursing and rehab centers have those systems because they have to pay for them on their own nickel, unlike the hospitals and the physicians where those systems were underwritten as part of the federal stimulus out of the Great Recession. It is still true that the United States pays a large percentage of its GDP for healthcare compared with other industrialized nations. What's interesting and unfortunate about that, relative to my earlier point, is that our healthcare outcomes are also less impressive than many of those nations. So as a country, historically, we spend more with expectations, with outcomes that aren't as robust, right? But in terms of actually the cost of healthcare and the percentage of that cost, the inflation rate of healthcare, it's actually gone down in the last couple of years relative to the passage of the ACA. So we're actually trending in the right direction. There's no doubt that with the aging of the boomers going forward, that the current system will have to be adjusted. It's not sustainable, but just purely based on demographics. But there are aspects of that system that are going extraordinarily well. Again, the Prescription Drug Act of 2003 actually turned out to be more cost efficient than what was predicted by the Congressional Budget Office at the time. The ACA has actually helped to contain the inflation rate of healthcare and sort of lower that and sort of change that trend. But when you have 10,000 boomers turning 65 every day for the next